Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be discussing on one of the another very interesting topic, that is systemic lupus erythromatosis, or we call SLE. Short form we call as SLE. As routine, we'll be discussing under these headings. We directly come to definition. It is an inflammatory multisystemic disorder where you get arthralgia, rash, which is the most common clinical features, and you can have involvement of multiple organs like brain, kidney, etc. And lupus is autoimmune disease in which body creates antigen that attacks different tissue, and lupus can be of three different variety like discoid variety, systemic lupus, and drug induced lupus. Lupus word is derived from a Latin which means wolf, and erythro means red, and that's why it is called systemic lupus erythromatosis. So it is an autoimmune inflammatory disease involving multi-system and multi-organs. So basically it is an autoimmune disease and it involves multiple organs. And organ which are being involved is skin, joints, kidney, brain, serous membrane, and multiple other organs. So central nervous system, eye, oral cavity, skin, cardiopulmonary, renal, GI tract, reproductive organ, blood, and even musculoskeletal system. There are what is called as the ACR criteria, where you got a skin criteria, systemic criteria, and laboratory criteria. In skin criteria, butterfly rash or a discoid rash, photosensitivity, and oral ulcer. While in systemic criteria, arthritis, serositis, kidney involvement, and CNS involvement. While in laboratory criteria, hematological abnormality, immunological, and ANA antibody. But there is Systemic Lupus International Collaborating Clinics classification criteria, where he has divided only two, clinical and immunological criteria, where you require minimum 4 criteria, at least one from clinical and one from laboratory, or biopsy proven lupus nephritis with positive ANA and anti-DNA. So in clinical criteria, acute cutaneous lupus, chronic cutaneous lupus, oral or nasal ulcer, non-scarring alopecia, arthritis, serositis, renal involvement, CNS involvement, hemolytic anemia, leukopenia, thrombocytopenia. So these are 11 criteria in clinical side, and as far as immunological is concerned, ANA antibody, anti-DNA antibody, anti-SM antibody. These three comes topmost on the list. Then comes anti-phospholipid antibody, low complement level like C3, C4, and direct CUM test in presence of hemolytic anemia. Depending upon the type of lupus, it is divided into 3 classical varieties: systemic lupus, discoid lupus, and drug-induced lupus. Systemic lupus means lupus plus multi-organ involvement. Discoid lupus mainly affects skin and it is non-fatal and may develop into systemic lupus if not treated. While drug induced is a variety of a systemic lupus, but etiology is because of certain medicines. Now, if you take at the antibody, almost ANA, DNA, and anti-Smith antibody, these are the most common antibody which are being done, and out of which ANA is positive in almost 95 to 98% of the group of people, while DNA antibody is only 40 to 60% positive groups, and anti-Smith antibody, that is in 20 to 30%, and these are other antibody which can be present. If you go through a etiology, mainly it is called genetic, environmental factors, and abnormal immune response. So hereditary or genetic, sex hormone, environmental triggers, immunological factors, loss of self-tolerance, and complement deficiency. So environmental factors, it is seen that in a monozygotic twin it is almost 25% incidence, while dizygotic it is only 3%, and in first relative and it is 3%, and antibody is seen in 20%. There are certain genetic characteristics, that is HLA-B8, DR3 in Caucasian, and in Japanese HLA-DR2. So SLA is mainly multifactorial: genetic, immunological, hormonal, and environmental factors. This is Epstein-Barr virus, genetic predisposition, maybe because of infection, maybe secondary due to hormonal factor, or abnormal immune response, which can lead to SLA. So there are good number of environmental factors like infection, antibiotics, that is drugs, ultraviolet light, extreme stress, certain drugs, hormones, etc. So these are all different multiple environmental factors. Ultraviolet light, infection, and big list of drugs, out of which the most common drugs, penicillin, sulfonamides, comes topmost on the list. Even isoniazid. These are some of the drugs. Prevalence is almost said that 4 to 250 in 1 lakh. In USA, 1 in 10,000. Onset before 8 years. It is absolutely unusual. Female, more prone, prepubertal 4:1 and postpubertal 8:1. It is rarely seen in a black African population. If we see the pathophysiology, we'll show you in the next slide how exactly the pathophysiology starts. These are genetic factors. So genetic factor, environmental factor, hormonal factors. So there are environmental factors like ultraviolet light, infection, drugs. These three are the most common. And genetic susceptibility. Most common is HLA-DR3 and DR2, where complement level are reduced, hormonal level are imbalanced. So hormonal factor play a role also, which gives rise to autoimmune proliferation. So there are hyperactive beta cells, or we call B cells, and T cells activation, and the ratio of CD4 to CD8 count is altered. There is a defective immune complex clearance, and there is an impaired tolerance, which gives rise to autoantibody production that will produce apoptosis, self-exposure, self-recognition. हेलो, हाँ बोलो. હા 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 કશો વાંધો નહીં હા હા foreign body cross reaction will take place. So, because of genetic predisposition, environmental trigger, these two are prime factors. There will be innate immune system activation, which will lead to adaptive immune system activation. There will be formation of an immune complex, which will give rise to clinical disease onset, aberrant amplification pathway, and irreversible tissue damage. So this cycle will continue. So genetic and environmental factor will give rise to increased autoantibodies formation, immune complex formation, complement activation, release of chemotaxin, leukocyte mononuclear cell activation, inflammatory factors will be released, and there will be destruction of the cell. This is a very simple diagram which will explain you everything. These are all predisposing factors. We call genetic factors, environmental factors. These are all genetic factors we call HLA D2, D3, 8, interleukins, etc. And in environmental factor, ultraviolet light, infections, female, Epstein-Barr virus infections, those are environmental factors. That gives rise to what we call as an abnormal immune response. And there is a defective suppressive network. Now this will activate, there will be antigen which will be activating beta cells and killer cells which will produce autoantibodies, immune complexes that will affect and release different chemical mediators which will involve skin, kidney, joint, blood, brain, heart, etc. And then it will end into what we call as a chronic stage or chronic inflammation which will produce damage to kidney and other organs, multi-organ damage. So very typical. I'll skip this slide. So cytokines will produce inflammation, will give rise to lupus nephritis, increase atherosclerotic process, and parenchymal brain damage. If we go to the clinical features, it is a multisystemic disease. The most common is involvement of skin and joints. In joint involvement, it is PIP joints most commonly involved, metacarpophalangeal joint, carpus and knee. Fever, anorexia, weight loss, malaise are the common features we call non-specific. A classical butterfly, malar rash, Raynaud's phenomena, splenomegaly, nephritis, pericarditis, pleurisy, these are all what we call as a serious involvement. And secondary to vasculitis, you involvement of CNS like stroke, myocardial infarction, hypertension, bleeding in stool, abdominal pain, joint pain and means arthralgia and arthritis, rash, livedo reticularis, eye, you can get involvement of retina, nasal bleedings like epistaxis, hemoptysis, involvement of the lung, glomerulonephritis, muscle involvement, and general symptoms like fever, headache, and weight loss. Now these are the common revised criteria what we call by ARA. We are putting one by one. Malar rash, which is a fixed erythema, flat or raised, sparing nasolabial fold, and that's why it is described as a butterfly rash. Or you can have a discoid rash, which is a erythematous rash, raised patches, adherent to keratotic scarring and follicular plugging. So this is that discoid rash. These are discoid rash. This is malar rash. Person will have a photosensitivity rash as a result of unusual reaction to sunlight. Oral ulcers are very common, which is very common in oral cavity. Naropharyngeal ulcers may be seen also, and sometimes they are painless ulcer. You can see these different ulcers. These are oral ulcer. Arthritis is non-erosive, involving usually two or more peripheral joints. Very commonly, we call metacarpophalangeal joints, carpal, knee, etc. Serositis means involvement of the serous layer like pleura and pericardium. So pleuritis and pericarditis, quite common. Renal involvement is mainly glomerulonephritis, which can produce proteinuria, hematuria, and there may be a cast appearance in urine, which can be RBC cast, granular cast, or tubular cast. As far as the CNS involvement is concerned, it is very commonly because of vasculitis, which can produce seizures or even psychosis. In blood, hemolytic anemia, leukopenia, lymphopenia, and thrombocytopenia. So this is involving hematological system. As far as immunology is concerned, anti-ANA will be positive, ANA antibody will be, anti-DNA will be positive, and anti-Smith body you will be able to detect. Even positive anti-phospholipid antibody. So ANA, anti-DNA, anti-Smith, and even anti-phospholipid antibody. If you come across more than 4 of these criteria out of this 11, definitely it goes in favor of SLE. And specificity and sensitivity, specificity is almost 95%. If you just look at this, arthralgia is almost in 95%, fever is in 90%, arthritis is in 90%, fatigue 81, skin rash in 74, anemia in 71, kidney involvement in almost 50%. Now pleural involvement, butterfly rash in 42%, photosensitivity in 30, alopecia in 27, blood clotting problems or we call hematological 20%, Raynaud's phenomena in 17%, mouth ulcer in only 12% of the group. So you can see the most common is joint involvement and skin involvement. Joint and skin, and common symptoms like fatigue, anemia, kidney involvement. So this comes topmost on the list. Again, you can see that hematological, fatigue, arthritis, skin, they are topmost on the list. And GI tract, peripheral neuropathy, ocular, pericarditis, they are relatively less. So this is classical malar rash. You can see this malar rash. It is a fixed erythema, flat or raised over the malar eminence, and this is spared. Nasolabial fold are spared. So it is characteristic. It is described as butterfly rash. Typical oral ulcer. This is discoid rash. Hemolytic anemia, leukopenia, lymphocytopenia, and thrombocytopenia. Lupus nephritis, or we call minimal change glomerulonephritis. Lupus nephritis, which will produce proteinuria and hematuria with cellular cast, RBC cast, etc. CNS, psychosis, headache, and even sometimes they can get convulsions, seizures. Typical photosensitivity. Typical photosensitivity. Arthritis, metacarpophalangeal joints, PIP, even carpal joints involvement, knee joint can be involved. In immunological, we already told you ANA will be positive. That will come here. Anti-DNA, anti-Smith antigen will be detected. So it is called anti-Smith antibody. Anti-phospholipid antibody will be positive. And in serositis, pericarditis and pleuritis, quite common. ANA will be strongly positive. This is together whatever we have mentioned. So secondary to all those involvement, typical butterfly rash, pleural effusion, pericarditis, lupus nephritis, arthritis, Raynaud's phenomena, common features like weight loss, fatigue, fever, arthritis, emotional lability, hemolytic anemia, thrombocytopenia, leukopenia, neurological disorders, Raynaud's phenomena, pericardial effusion, kidney involvement will produce proteinuria, hypertension, renal failure. As far as respiratory system is concerned, pleurisy, dyspnea, photosensitivity, butterfly rash. These are all explained in one single. And in a blood, you will have a ANA positive, anti-DNA positive, anti-phospholipid positive, and anti-Smith antibody positive. Another way to remember, whichever way you want to remember, malar rash, discoid rash, ANA, mucosal ulcer, CNS involvement, pleuritis, pericarditis, hematological, arthritis, renal, and photosensitivity. And these are the anti-phospholipid and anti-Smith antibody positive. Another way of remembering serositis, oral ulcer, arthritis, photosensitivity, malar rash, discoid rash, blood, kidney, anti-nuclear antibody, immunological picture, and CNS. These are typical different types of rash. This is classical butterfly rash. These are some of the discoid variety of rash. These are discoid variety. This is photosensitivity. This is typical butterfly rash. This is bullous lesion. This is discoid. This is butterfly rash, classical butterfly rash. These are other rash, other variety of rash. You can see that typical rash. You can see Raynaud's phenomena. You can see Raynaud's phenomena. And along with Raynaud's phenomena, you get ischemic damage, typical rash. Lot of pictures we have got. These are discoid rash. These are different type of rash. These are discoid rash. These are photosensitivity. It will be on the exposed part. This is discoid rash. This is livedo reticularis. Typical picture of livedo reticularis. This is lupus profundatus. You will have scarring and fibrosis. Profundus, lupus profundus. These are all discoid rash. This is alopecia occurring along with discoid rash. This is vasculitis producing Raynaud's phenomena and ulceration and even amputation. This is alopecia involving the scalp, different types of alopecia. You can see alopecia will take place along with rash. These are oral ulcers. You can see typical oral ulcer. Classical Raynaud's phenomena we have already discussed before. Pallor, cyanosis, and it can be involving one finger or multiple. So if you want to find out it is an active or not, and arthritis involvement is active or not, you will have to go through history, physical examination, and laboratory parameters. I'm not going into detail regarding that. These are the different types of involvement. Also, we call it the Jacob's arthropathy, which is not very common, but you can come across, that is with deformity. You can have avascular necrosis of head of femur as a part of vasculitis. Neuropsychiatric involvement, you can have a peripheral neuropathy, almost mimicking like Guillain-Barré. It can be mononeuropathy or polyneuropathy. And in CNS involvement, you can have a lot of involvement along with SLE, acute confusional state, anxiety, aseptic meningitis, cerebrovascular disease, headache, demyelinating syndromes, mood disorders, myelopathy, seizures, psychosis, etc. There is a big list. You can have presentation in any form. This is kidney involvement. These are different types of respiratory involvement, right from pleural effusion, pleuritis to pleural effusion, pneumonia, interstitial lung disease, hemorrhage, pulmonary edema, shrinking lung syndromes, restrictive lung, etc. In cardiac pericarditis, pericardial effusion, even you can have myocarditis, coronary artery involvement, Liebman's sac endocarditis, valvular insufficiency, particularly MR, you can have a cardiomegaly, and even you can have a myocardial perfusion defect leading to ischemic heart disease. So you can have a pericarditis, myocarditis, Liebman's sac, etc. Hypertension, even congestive heart failure. GI tract, pancreatitis, dysphagia, peritonitis, all these are partly because of vasculitis. Hematology, we already discussed thrombocytopenia, leukopenia, lymphocytopenia, and immune hemolytic anemia, where you can have a Coombs test also being positive. This is initial assessment. If you are interested, you can go through history, physical examination, laboratory parameters, and then you can find out the activity. So, a big list. You can go through your leisure time. So, in investigations, we require CBC, serum creatinine, urine analysis to find out involvement of kidney like lupus nephritis, where you will have a proteinuria, hematuria, cast will be present, creatinine will be elevated. As far as CBC is concerned, anemia, you will have a leukopenia, lymphocytopenia, thrombocytopenia will be seen. You can find out the inflammatory markers. DNA antibody will be positive, complement level will be reduced, ANA will be positive, anti-Smith antibody will be positive, and also you can have phospholipid antibody will be also positive. This we have already mentioned in previous slides that almost in 95 to 98% of the people ANA will be positive, complement level will be low, DNA antibody will be positive, leukopenia, anemia, proteinuria. In Sjogren syndrome, you can have a SSA antibody, SSB antibody positive. You will have a thrombocytopenia, anti-Smith antibody. Liver function test may be abnormal. You can have a thrombophilia, splenomegaly, etc. Renal involvement, you can make out by proteinuria, creatinine elevated, complement level low, renal biopsy will be necessary. As far as respiratory system involvement is concerned, you will have to go for pulmonary function test, HRCT. In cardiac, ECG, 2D echo. In blood, Coombs test, and antiphospholipid antibody, antiplatelet antibody. Even you can go for a bone marrow examination. In CNS, CSF examination, CT, MRI or PET scan may be necessary. and where you can have antiphospholipid antibody will be positive. These are all the different types of blood tests which will be available: urine analysis, creatinine, metabolic panel, ESR, complete blood count. What will be the finding? In serology, we call as a anti-DNA antibody will be positive, ANA will be positive, antiphospholipid will be positive, renal biopsy. These are all the different types of autoantibody which will be, you can see that ANA will be strongly positive, DNA will be positive, quite common, and this will be in which disease it will be positive. So ANA is strongly positive, and you will have other antibody, antiphospholipid, then anti-Smith antibody, etc. Management, there is no permanent cure. Complete sustained remission is also not very common, difficult. Main goal is to suppress the symptom and prevent the organ damage. The prognosis will depend upon the severity of the disease and how fast you treat. Mainly, you have to prevent complication of the disease and see that you give a proper treatment. So, algorithm is symptoms complex suggestive of SLE. You will go for ANA, CBC, urine examination, platelet count, etc. So, you go for all this different investigation and try to find out how severe the involvement is. These are all the different tests which are being done, and you try to find out the stage. There is a non-pharmacological management like sunscreen use, which can protect the skin from photosensitivity, smoking cessation, weight loss, regular exercise, blood pressure control. You can supplement with vitamin D. You can avoid high dose of estrogen, particularly oral contraceptive pills. Avoid sulfonamides. Avoid pregnancy because the drugs which will be used will produce side effects. And these are the flow charts which are available. So you do what is called as a non-pharmacological protection, and then with specific involvement, what you do. If there is no involvement, usually you go for NSAID, anti-malarial and glucocorticoids is preferred. If it is lupus nephritis, you will have to go for glucocorticoids, cyclophosphamide, or you can go for glucocorticoid and anti-suppression, immunosuppression drugs. If there is a neuropsychiatric, anti-malarial, anticonvulsant, antidepressant, glucocorticoid and immunosuppression. These are all the different types of therapy you can select. So depending upon the involvement, these are all the emergencies: CNS, systemic vasculitis, thrombocytopenia, nephritis, alveolar hemorrhage, etc. are emergency. And usually the treatment which is selected is NSAID, chloroquine, steroid, and these are all immunosuppression: cyclophosphamide, azathioprine, and mycophenolate. And these are what we call as plasma exchange you can go for, IV globulins you can go for. Usually you should use the drug with least side effect, lowest dose to control the disease and long-term damage prevention. In a mild disease, by and large, steroids should be avoided. In severe disease, aggressive treatment should be given. So these are all the different, this is FDA approved, glucocorticoid, anti-malarial, NSAID and biological compounds. While off the label use, cyclophosphamide, azathioprine. And you can try methotrexate, leflunomide and IV immunoglobulins, which is described as a borrowed drugs. So the most common utilized is NSAID, antimalarial, that is hydroxychloroquine, glucocorticoid, and in immunosuppression cyclophosphamide, methotrexate, azathioprine, and mycophenolate. In blood disorders, you can go for stem cell transplant, IV globulins, and biological compounds. Plus, you can use cyclophosphamide or glucocorticoids. Complications which are very common are life-threatening complications like digital gangrene, cutaneous necrosis, thrombocytopenia which can produce bleeding, autoimmune hemolytic anemia, catastrophic antiphospholipid syndrome, pericardial tamponade, myocarditis, pulmonary alveolar hemorrhage, spinal cord involvement, that is myelitis, mesenteric vasculitis, involvement of the colon and small bowel, pancytopenia, nephritis, arthritis, neuropathy, etc. And secondary to systemic involvement, hypertension, growth retardation, chronic pulmonary involvement, ocular involvement, permanent renal damage, neuropsychiatric symptoms, musculoskeletal involvement, gonad, hypogonadism can occur. So I end my lecture here. I thank you all. I know your time is valuable and I appreciate you for spending some of the time with me. So I end my lecture here. You will see good number of time this group of people, what we call as the SLE. I hope this lecture will be very helpful to you.